So this is a study looking at ureteral stents post-ureteroscopy and whether they affect patients visiting the emergency room after their procedure. The decision to leave a ureteral stent after ureteroscopy is often subjective and based on multiple factors. The degree of ureteral manipulation, the duration, and presence of any ureteral injury are some of the factors that are considered. There have been no guidelines to say definitively when you should leave a stent. However, recently there have been some data, some randomized clinical studies that have supported not routinely stenting patients post uncomplicated ureteroscopy. The benefits of not routinely stenting these patients that have been demonstrated include less analgesic use, less irritative voiding symptoms, lower readmission rate after ureteroscopy, lowered cost, and an equivalent stone-free rate. Critics of these data cite that in a patient without a stent who presents to the MERGE with some complication may require urgent workup and urgent stenting in this situation, and that the definition of quote-unquote uncomplicated ureteroscopy is fairly unclear and is not definitely not unified among these recent studies. So the purpose of our study was to determine in our experience if stenting was related at all, just specifically to ER admissions after ureteroscopy. What we did was we examined consecutive patients undergoing outpatient ureteroscopy at St. Paul's Hospital. These patients received either flexible, semi-rigid, or combination ureteroscopy for varying stone sizes and varying locations. Some had unilateral, some had bilateral manipulation. Some had an access sheath and additional manipulation in the form of balloon dilatation used. All patients were discharged with analgesia and antibiotics. Stent criteria for stent placement in the study included decision by the primary operator on whether there was a presence of ureteral mucosal injury, any ureteral edema at the end of the procedure, if there is contrast extravasation at any point in the procedure or at the end, and if there was prolonged ureteral manipulation. 6 French 24 to 26 centimeter double J stents were used, and stents were typically removed 2 to 3 days post ureteroscopy. Primary outcome measure was the frequency of emergency room visits within 30 days of ureteroscopy, and we also looked at the reason for the emergency visit where possible. Statistical analysis was performed, and age, sex, and stone burden were controlled for, and various subgroup analyses were performed. So 79 patients were examined with a mean age of 53 years. Most of the patients were men. Stone location included kidney and collecting system, proximal ureter, and distal ureter, less commonly. The median stone diameter was 9 millimeters, and almost 3/4 of patients were stented based on the previously discussed criteria. A summary of our results comparing the stented to non-stented groups. The groups were similar in patient characteristics, age, proportion of males to females, and stone characteristics. Access sheath use was more common in stented groups. In the stented group, this was not statistically significant. We did see a slightly higher emergency room visit rate in these stented patients. However, this did not reach statistical significance. Comparing subgroups, we found no increase in emergency room visits for unilateral versus bilateral ureteroscopy patients. Balloon dilatation didn't make a difference. Access sheath use in and of itself did not make a difference to emergency room visits, and the location of the stones manipulated did not make any difference. Looking at reasons for emergency room visits, there were three main categories. These included lower urinary tract symptoms or hematuria, infection, and colic. Colic was somewhat more common in the stented group. This was not significant again. So in conclusion, we found that almost a quarter of patients after outpatient ureteroscopy did present to the emergency room. Stenting did not make a difference to this rate, and we therefore conclude that the identification of uncomplicated versus complicated ureteroscopy is quite subjective and difficult, and that the decision to stent should be individualized. Thank you.